Hi, my name is Kalia Stanford. I will be doing my interview at the Emory Eye Center for Business 115, Introduction to Business and Technology. Again, my name is Kalia Stanford. I will be doing the introduction, a interview for Introduction to Business Technology with the next person that you'll be seeing is Shakiria Mosley, which is a technician at the Emory Eye Center.
Hi, I'm Shakiria Mosley, and I'll be talking about some of the changes that have transpired in ophthalmology over the past several years.
How long have you been in ophthalmology, Shakiria?
I've been working in ophthalmology for 5 years.
How long have you been at the Emory Eye Center?
I've been here for a year and a half. I've learned quite a few things during my time as opposed to the things that I saw in my previous office and here.
Going from your previous office to this office, what's the biggest change that you noticed?
Different technology. Emory has a lot more advanced technology than where I came from. There was quite a few machines here that I had not seen, as opposed to the projection screens here. We have some that are on the LCD screens as opposed to the old manual projector that we used to use.
At the center that you came from previously, how many employees were employed there approximately?
Approximately 60, 65.
And when you came here to Emory, in total, how many employees do you remember it about being?
Approximately about 160 employees. 30 are technicians and 43 are doctors, and the rest are administration and research.
And can you tell me, as a technician, what are some of the changes that you've seen in ophthalmology that has made your workflow better or easier?
One change is the way that we check the intraocular pressure, also known as the IOP. I always get patients asking me, what happened to the puff of air? And I say, no, we don't do that anymore. We've advanced. There used to be a non-contact method where we would place the patient in front of a machine that would just blow air in their face.
So, Shakiria, can you please tell me what is the first advancement in technology that comes to your mind when I ask about technology?
First thing that comes to my mind is the way we monitor intraocular pressure, which is also IOP, which is the amount of pressure that's within the eye. I have a lot of patients that ask me, what happened to your puff of air? And I say, oh, we don't do that anymore. And I'm like, oh, I didn't know that. So we have here one technique is applanation, the Goldman applanation, which is we place an anesthetic in the patient's eye, place a small prism here, just on the surface of their eye, and we're looking at two wires that we're looking to meet like this. So once we turn our knob here and get that, that's when we find our intraocular pressure. Another method is called the eye care. This is a handheld device. This does not require you to use an anesthetic. What we do is place a tip here. It's like a small Q-tip. We place it in here. Let it set. We just place it in front of the patient's eye, and we just press this button, and during that, it just takes a reading, and it shows here on the screen.
So that's more of a digital version of what you just showed as far as the Goldman applanator,
Yes.
correct?
Yes, it is. Another version that's digital is the tonal pen. We do place an anesthetic in the eye for this one. Press the button, do a couple of taps on the patient's eye, and it gives us a reading here on the screen.
So, between the two of those, which one do we use on our children?
Children, this is more child-friendly. A lot of patients that we can't, it's difficult to get drops into a patient's eye, especially a child's eye. So this helps us to move quickly. We can go in and out, give them a moment to take a breather, do a couple of quick taps again, and then we'll get our reading here.
And previously, even in the past, prior to having these three versions, tell us a little bit about the other non-contact version.
We have the non-contact version of the pneumometer, which is just basically in front of the eye, just a quick.
So, did patients respond well to that piece of equipment?
No, they did not. They did not like having a puff of air blown into their face, because they're sitting there and they're very anxious and they're like, oh my God, this air is coming into my eye. What do I do? We always say just relax, keep breathing, but they don't quite understand that all the time.
So something else that we had talked about earlier was the way that we that is now a way to gather information about a patient's prescription. Can you show us the older version of checking a person's prescription?
This is the four-opter. The prescription consists of the sphere, cylinder, and axis. Now, this is just the manual way of doing it. So you can, start from scratch here. Everything is set at 0. And your axis is set here at 180. So we give the patient a line on the screen, on the projection screen, and say, can you read this? Patient is able to read that. We'll start by closing one eye. We'll go up a couple of diopters and say, which is better, 1 or here at 2. Based on what the patients tell us, that's where we make our adjustments. They may say 2 is better.
So, in other words, this is based off the patient's.
Yes, this is very subjective because we can't just automatically say, oh, I think you're going to be a -1 today. No, we have to ask the patient which lens is clearer to them.
So, when we go further into this interview, what will you be showing us?
I will show you what we call the auto refractor, which is basically the patient is just sitting at the machine. The machine just automatically takes measurement of the patient's cornea, and it prints out a prescription just like that. This is the automated way to check a person's prescription as opposed to the four-opter where we have to ask the patient to tell us which lens is clear. All we do is have the patient put the chin in here and forehead to the bar. We zoom in here. Can I turn right up? They're looking here. We tell them to focus on the picture that's in there. The machine automatically finds the eye and gives us an estimated prescription. And that'll be a starting point for us once we start to do the refraction process. Yes, that's supposed to be blurry. Don't blink. Okay, ma'am, you can sit back. It prints out a prescription here, so we have a starting point here.
So in a recap, instead of asking them better 1 or better 2, this is the way we get a prescription.
Yes, just a starting point. Instead of this is used for patients who can't really tell us whether or not, oh, that's better. No, I don't think that's okay. This is just a starting point for us. This is a digital monitor as opposed to the old projection screen that we used to use. We have more of a variety to show patients. We can show them letters. We also have numbers, pictures for children and patients who don't recognize letters and numbers. We also have the E's. They can tell us up, down, left, and right. We also... This is the electrophysiology room. This is where we go, we bring patients in here to do testing for abnormalities in the back of the eyes, such as retinopathy. It consists of a setup of dilating both the patient's eyes. We clean their forehead and temple areas and place electrodes like this in that spot. We also numb their eyes and place an electrode, which is known as a DTL, along the lower lid. And the setup is similar, is exactly like this. And that's the electrooculogram, EOG. That's an ERG where they have it on the side, and that's the DTL running through their eye, an electrode there. And we just plug them up to the monitor here. And then it emits waves so we can look at, so the doctors can measure the wavelengths of what's normal and what's abnormal. And this is a normal one. This is on a patient. This is the right eye.
So in a patient that has an abnormality, it shows that they have a decrease in their...
Yes, it could show that the waves are flat as opposed to having the peaks and valleys.
So that means if they had low peaks and valleys, they didn't have very much electrode?
No, and that means there's something that's going on in the back of their eye that's caused them not to see normal.
Okay. And how many settings or doctor's offices in this area, in the metro area, have this?
This is the only one in the metro area. We get a lot of outside patients that come from here, come from metro Atlanta, North Georgia, South Georgia, Tennessee, Florida, Alabama, all over. They send their patients here to have this special testing. This is the antique projection screen that projects an image into a mirror and it bounces back onto the wall. That projects an image into a lower mirror here, and the patient is able to read the letters that they see. This is estimate of 2020. What was 20 feet? So the patient is 20 feet. You know, this room is not 20 feet long, but it is 20 feet. So the patients just tell us what they see. We go from 2400 all the way down to 2010.
So in this room, everything is manual versus
manual, so everything as opposed to the digital monitor
downstairs, which was like a TV remote control.
TV remote control, yes. This we have to, manually move up and down to the patients who give us, tell us what they see.
So overall, Emory right now is going through a change where...
Yes, we're going through a renovation phase. Eventually this room will be renovated and it will look just like the ones that you saw earlier with the digital monitor. So we're just basically just taking a slow step into the new millennium.